Assalamu alaikum and welcome to this lecture on discussing different approaches to abnormal vaginal bleeding. First of all, if we want to discuss abnormal vaginal bleeding, we have to know what is abnormal vaginal bleeding. For that, we can say, first of all, determine what is normal. So abnormal is menorrhagia, which is very heavy but regular bleeding. It can be metromenorrhagia. In the past, it was called metromenorrhagia, so prolonged, possibly heavy bleeding. Oligomenorrhagia or oligomenorrhea, which is so not so common, not so frequent bleeding, but heavy. And postmenopausal bleeding. Those are the main kind of conditions we're going to focus on today. But first of all, as I said, we have to also distinguish what is normal. So we know what is considered normal. Characteristics of a normal menstrual cycle are that it is regular, so about monthly. It is normal blood flow, so no clots, no anemia. It is manageable for the patient, so not overwhelming blood loss that makes it difficult to function for her, and also that it's not too long. In numbers, this would be a cycle between 2 and 8 days bleeding every 21 to 35 days. All of this within these numbers, within this range of numbers, can be considered normal. What we cannot represent in these numbers, however, is the impact the bleeding might have on the patient. So, although maybe we say 8 days bleeding every 21 days is normal, the patient might find this very unmanageable for her, and she will think that she's bleeding most of the days, most of the time, and she will not really be able to manage this very well. And if that is the case, so if only the patient reports up kind of the severe impact or impact of the or adverse impact of this bleeding on her function, on her daily life, this can also be considered abnormal. So in assessing bleeding by women, in looking at menorrhagia, we don't, or heavy bleeding, unscheduled bleeding, irregular bleeding, annoying bleeding, we're not only looking at the pathology of it, we're not only looking at the significance in the term for the doctor, for the gynecologist of it, because maybe for you, the gynecologist, the doctor, bleeding 8 days out of 21 is not significant, and you can say, well, this is normal. But we're not only looking at that. In the first is we're looking also at the woman. She has to live with that cycle, and you have to treat her and find ways to make this more manageable for her and help her function throughout her day or throughout the month. So we're going to go and discuss these issues now with several cases that we are going to go through. So the first case is a 46-year-old woman who has never been married and has no children. She comes to see you because in the last 2 months she has had a long period. Previously, her cycle has always been on time. She's worried that something might be wrong. She has no other past medical history, no drug history, no allergies, and she's a school teacher. What do you want to do next? You need to get a little bit more of the history, that's right. So you want to ask a little bit more about the duration, extent, the heaviness of her period, regularity, pain and other associated symptoms, impact on her social life. After all, she is a teacher. You want to know her contraception, but she's not sexually active. The bleeding, she tells you that the bleeding is heavy for 3 to 4 days. She has no particular stress or change at home. Next follows the examination. The examination has to include an abdominal exam, which you find a normal uterus, which is not palpable, a speculum exam, where the cervix looks normal, and also a pervaginal exam, which is there's no pain, the uterus is normal size and mobile, and the adnex also appears normal. So what do you need to do next? You need to look at some investigations. You do an ultrasound scan, and for investigations in these points, mostly a transvaginal ultrasound scan and a hemoglobin has to be done. So the hemoglobin for this woman is 11.8, and the ultrasound scan shows some the right ovary. You can see in the upper picture, you can see the white ovary with some kind of persistent simple cysts in there. And on the lower picture, you can see a normal looking uterus with quite thick endometrium, but this is normal in her age group when she still has periods. So what is the differential diagnosis in this woman? Hold the video here, take your pen and paper and write them down. This can be perimenopausal bleeding. After all, this patient is 46 years old, and so she might start with the perimenopause and have some anovulatory cycles, some things where it takes longer and then is heavier. There might also be an irregular cycle due to some short-term factors, which she actually denied. And there might be endometrial pathology on top of that, which might be fibroids, a polyp, or even cancer. So cancer would be endometrial cancer, as the cervix looked normal. This is probably lower down the list in this patient, as in this age group you see endometrial cancer, but it's not very common. So what is the management for this patient? Again, pause the video and write it down. You can offer her tranexamic acid for the days of her heavy menstrual flow. So this would be 1 gram 3 times a day, but it's important that she only takes it when she bleeds heavily and only not more than 4 to 5 days each month. However, this does not regulate her cycle. Her cycle will remain quite long, so therefore you can also offer her cyclical progesterone to regulate the cycle. So she could have progesterone to take from 5 to 26 days of the cycle, and then she can wait. Once she stops the progesterone, she will have a withdrawal bleed, and then she can wait until she starts bleeding again, and on day 5 she will restart the progesterone, and she has a bleed-free interval again for 3 weeks. And then once she stops the progesterone, she will have a withdrawal bleed again, and this will regulate her cycle. But what if this does not regulate the cycle? What if you give this a try and she wants to try this, but it does not regulate the cycle? Then she needs to have a further investigation, and this would be a hysteroscopy and an endometrial biopsy, because if this is not regulating her cycle, there might well be an underlying anatomical problem or other problem. This patient might also say, I don't want to take tablets all the time, and this is a common response by patients. In that case, you can do a hysteroscopy or endometrial biopsy immediately, and if this is normal, you could, for example, offer her a Mirena, an IUS, levonorgestrel IUS, where you have some progesterone in the stem of the inserted coil, and this kind of reduces the blood flow considerably. Only if hysteroscopy and endometrial biopsy are not available should you consider dilatation and curettage in this patient. Really only as a means of getting an endometrial biopsy from her. So further management options, we already said the Mirena IUS, levonorgestrel IUS. This is a very, very powerful tool which is used much, not enough in Gaza actually. It is very good for treating abnormal and heavy bleeding when there's no underlying other cause. The progesterone that is released within the cavity thins out the endometrium over time and then causes either very slight bleeding or actually amenorrhea. And of course, patients have to be counseled about this, and this has to be explained to them. Often this period of thinning out of the uterus, of the endometrium, has got causes a time of irregular bleeding. So this has also got to be explained to the patient. Endometrial ablation is another treatment choice. The problem here is this will reduce the bleeding. Endometrial ablation means can be done by thermal balloon ablation or microwave ablation. In any case, there's a device put in the uterus and like, for example, a balloon that is blown up with a hot solution of electrolyte, and this burns away the endometrium. However, it will never be complete. The endometrium, there might always be some islands of endometrium lost, which can also cause bleeding, ongoing bleeding. And this so if you have irregular bleeding will continue. But if you only have heavy bleeding, then this is a very good option to go by. Okay, so let us go and talk about the next case. So the previous case, I just want to say that whatever option you choose for this patient, it has to be agreed with her, and the patient has got a very should be included in the decision-making process. Next, a 26-year-old patient always had heavy periods. These are regular but heavy for 4 to 5 days. In these days, she finds it difficult to look after her small children. She is married with 2 small children under 5 and does not work. She had 2 normal deliveries. What are you going to do next in this case? Yes, you're going to complete the history. She has no other symptoms except for pain during her period. Her smallest child is just 9 months and she does not want more for another 2 years. She has no other past medical history. She doesn't take any drugs, allergies, and family history. All is clear. What do you do next for this patient? You have to examine her. So you want to palpate the abdomen, see if the uterus is palpable or not, do a speculum examination to assess the cervix. This is also an opportunistic chance to make sure this looks normal. But what do you do next? An ultrasound scan shows, and a full blood count is always opportune in these patients, so you do not want to miss fibroids or any such other problems. And here you can see that she has got that her hemoglobin is 9.8, so it is rather low. Her uterus looks normal, and also the ovary looks okay. This might be a PCOS occurrence, appearance of the ovary, but it is really not enough follicles for this probably, and she doesn't have the hallmark symptoms with it. So you have to maybe just register that and keep that in mind at the moment. So what management can you offer this patient? Please jot down your options that can be offered to her. In this patient, you didn't find any real pathology. So but you found that her menorrhagia really impacts her life and that it is severe as her hemoglobin is low. So you have to, you can suggest to her the combined oral contraceptive pill. She has no other problems, medical problems, no family history, and she does not want children at the moment. So this could be a good option for her. First of all, it regulates her cycle. Secondly, it makes it manageable, and it might be very useful for her. She could also have as a choice the progesterone-only pill or the depot injection with progesterone, so medroxyprogesterone. These have are a little bit problematic. The progesterone-only pill can sometimes cause some irregular bleeding, although there are some newer and better pills which also cause amenorrhea mostly, and are also very good to take. The injection, you have to warn the patient that this is good because the injection you have to only take it every 3 months. Initially, it causes some irregular bleeding, but not heavy. Later on, after 2-3 injections, it mostly causes amenorrhea. But there's 2 drawbacks with this treatment. First of all, it might cause weight gain. This is the only contraception that is really associated with weight gain. And secondly, if she wants to have children later on, it might delay her fertility. So her fertility might come back delayed. This is not the case with all women, but it can happen. Finally, there's also the Mirena IUS, which is would be very useful for her if she was not wanting to take a tablet every day, or if she was going to think that she might forget her tablets. Then this might be a very good alternative for her if she were happy to have an IUS. The next patient is a 38-year-old patient who comes to see you with heavy bleeding. Her cycle is regular, but on the first days of heavy bleeding, she cannot go out, as she is scared that she might have to change her pads, and she'll be in a mess. She often has to change her pads every hour. She works in an office and loses days of work every month. She gets some pain with her heavy periods, but her main concern is the heavy bleeding. What other things do you need to ask? So this patient denies postcoital or intermenstrual bleeding. She has no urinary or bowel symptoms. Her last menstrual period was 2 weeks ago. For contraception, she uses condoms. Her obstetric history shows a normal deliveries without complications. She has asthma and uses Ventolin and Becotide, but she has no allergies and no family history. So you can see this question for postcoital and intermenstrual bleeding. That should be a question that is always should always be included, especially if you're not quite sure what is meant. What do women mean with with irregular periods? If they are very clear that their period only comes every month, then it might be a question that might not need to be included. But generally, it's always a good idea because, of course, it can give you a hint to other problems such as cervical polyps, other cervical problems such as infections, chlamydia, gonorrhea, or even cervical cancer. On examination, her abdomen is soft and non-tender, and her uterus is not palpable. Speculum examination is normal. On vaginal examination, the uterus is normal and non-tender, but it appears large. And then you do an ultrasound scan, and this shows, and you can see on the left, this shows fibroids. You can see this on the left picture at the bottom. You can also see it in the middle picture. There's kind of a fibroid, that kind of an intramural fibroid that kind of impinges onto the endometrium. And then you can see the right lower picture is a picture of an MRI scan, which really demonstrates several fibroids very well. And her hemoglobin is only 9.5. So what is the management for this patient? Really, she has got, although we think our fibroids need to be removed, she also has several management options, and it depends on what she chooses. Tranexamic acid can be given when she bleeds heavily, because she said she only has 4 to 5 days. So if it can be managed with that and she's happy with that, that is one choice. She can also use the IUS if it's not submucous fibroids. If you can exclude submucous fibroids, she would need a hysteroscopy for that. Then she can also have the IUS, and this might also work. She could have the progesterone injection, the progesterone only pill, or even cyclical progesterone to kind of manage her bleeding. You can see that I did not include combined oral contraceptive pill, really because she's 38 and above 35. It is not always recommended actually to start. It's not recommended to start the combined oral contraceptive pill anew due to the increased risk of venous thromboembolism or even stroke. But there's another choice, which is ulipristal. Ulipristal was developed initially as postcoital contraception, so it's a progesterone. But it was found to also work for menorrhagia when there are fibroids. But the fibroids should not be larger than 3 centimeters, so this has to be assessed carefully to avoid disappointment. Sometimes an endometrial ablation works, but then there's also surgery. If we talk about surgery in a patient who has a complete family, a hysterectomy should be preferred to a myomectomy. If a patient has not completed her family, then you have to discuss this with the patient carefully. A myomectomy can be a difficult procedure with complications such as adhesions and kind of make child impinge on fertility in this way. But it might also, of course, help with the patient. So it depends very much on where is the fibroid, what type of fibroid, can it be removed easily, or is it difficult to remove, and does it kind of make the uterus weak if it's removed. So this has to be assessed very carefully and discussed with the patient. Case 4 is a 65-year-old woman who comes to see you. Her last period was over 10 years ago, but she experienced bleeding again recently. She knows that this is not normal. So you want to ask how many episodes of bleeding did she have, and she tells you that she has several episodes of PV spotting or light bleeding for the last 2 to 3 weeks. But she has no associated symptoms. So postmenopausal bleeding is always worrying, but it is more worrying if there are repeated and persistent episodes. If there's just 1 or 2 episodes, then it might be that she has had some infection or some soreness, something like that caused it. But if there are repeated episodes and maybe worse, strong episodes, or maybe increasingly episodes in increasing strength over 2 to 3 weeks, then it is very worrying. She has had 4 normal deliveries in the past. She does suffer from hypertension and does take amlodipine for it, but has no other family history. So what do you do next? You have to do an examination. In her there's no mass and no tenderness. The speculum shows a vagina which is slightly atrophic. The cervix is normal and there's no active bleeding seen. What do you do next? Of course, you have to do a transvaginal ultrasound scan. This is very important in this patient. You need to assess the endometrial thickness, and you also need to have a look at the ovaries in this age group. So this is a picture of the endometrial thickness, and it does look completely normal. However, you always have to measure it. You should not just kind of say, oh, this looks normal. No, you have to measure it. It has to be below 4 millimeter to be normal. In this ultrasound scan, you can see that this endometrial thickness is increased, and it is well above 4 millimeters. In a patient, in a premenopausal patient who still has periods, this might be absolutely normal within the cycle. But in a postmenopausal patient, and this patient is 65, so she's about 15 years after her menopause, this is an abnormal ultrasound scan and is very worrying. So here you have another picture of a transvaginal ultrasound scan, and you see a thick endometrium, but you also see some kind of lakes or anechoic areas in it, and this is often seen in hyperplasia, or even adenomyosis can look similar. But in a patient who's after the menopause, you do not expect adenomyosis, because endometriosis and adenomyosis reduce if the estrogen has gone. So in such a patient, you would rather expect hyperplasia possibly. So in this case, just to finish this, in this case, if you have a thickened endometrium like that, you have to do an endometrial biopsy or a hysteroscopy to know, in order to get a biopsy and to be assured to look at this biopsy with pathology to exclude or diagnose endometrial cancer. It is only 10% of women who will have endometrial cancer. So 10% of those women presenting with postmenopausal bleeding, only 10% of those will have endometrial cancer. A 37-year-old patient comes with a history of persistent postcoital bleeding. She describes that this has been going on for 2 to 3 months. At first, not after every time, but more recently, she experiences postcoital bleeding after every intercourse. She describes it as being bright red blood, less than a period, but bleeding, but needing a pad. What other important questions do you need to ask here? Stop the video, write them down with a pen. Okay, so very important in this patient is the sexual history, because especially you have to ask if she has had sexually transmitted infections before, or if she had any contact recently that made her at risk of sexually transmitted infections. This patient is married and has no history of sexually transmitted infections and has had 2 deliveries in the past. What next? Also, she's married and she has had no other partners. So what next? You have to examine her. And in this examination, what is especially important? The speculum examination is the most important examination in this patient, as postcoital bleeding actually can stem from either an intravaginal lesion or more commonly from the cervix. Here you can see 2 pictures from speculum examinations that show the cervix, and both of them look completely normal. I want just to point you to the picture on the right. You can see the vaginal walls as well as the cervix very, very well, and you can see that this speculum examination is done with a single-use plastic see-through speculum. These single-use speculums are not only very good because they are single-use and therefore in infection control terms they are very good, but also they are useful because you can look through them and actually inspect the whole of the vaginal wall. And these are abnormal cervixes. So these are speculum examinations from abnormal cervixes, just as examples. So if you see anything abnormal, you have to look at it in more detail. Although she tells you that she has had no other sexual partners, you have to check for chlamydia and gonorrhea and other sexually transmitted infections. So you have to do the swabs for that. After all, her husband might have had some contact with others, so it's always important to exclude those. But if you see abnormalities of this on the cervix, you have to also arrange a colposcopy examination, and this on the left hand side is probably a picture from a colposcopy examination. As you see the white staining, this is aceto-white staining on the cervix, and this is abnormally looking aceto-white staining, and you can see that because it has got a very hard edge and is very thick aceto-white staining. So this patient, both of these patients need um, um, urgent biopsies from the cervix. So what is the management? This depends, of course, on the stage of the abnormality kind of discovered. If you find an abnormality in the way of, so if you find an infection of a normal cervix with present infection, you need, of course, to treat them. But if there's no infection and the cervix looks abnormal, as in the previous two pictures, you need to do your assessment depends on the stage. If you think it's an early stage or just CIN stage 1, you can't really clinically see it very well, but you can just see the aceto-white staining, then you have to do a large loop excision of the endometrium. However, if there's a larger, if you can already see some clinical abnormality on the cervix in the form of cancer, then you have to send it to a multidisciplinary team. They have to then stage the patient carefully and then plan the appropriate treatment. And we have discussed that in the recorded lecture on cervical cancer. So in summary, abnormal vaginal bleeding can have a serious underlying pathology, although it is mostly not due to a very serious pathology. Menorrhagia in women under 40 is not usually indicative of a malignancy, but needs treatment as it can affect women's lives. And also, so menorrhagia means regular heavy bleeding. And also, if it does not respond to treatment, it has to be investigated further. Treatment of menorrhagia should not involve hysterectomy. Or not usually involve hysterectomy. There's now so many other ways of treatment, such as the Mirena IUS ablation, endometrial ablation, that can actually lead to good treatment, ulipristal, that can lead to good results that the patient feels happy with, and therefore she can avoid a major surgery. Irregular bleeding in women above 40 or postcoital bleeding or postmenopausal bleeding are red flag symptoms and need to be investigated very carefully. Thank you very much for listening to this lecture. If you have any questions, please write them down and we will discuss them in our kind of discussion session this week.